Spin Essentials, the core topics in pediatric neuroimaging essential for daily practice, packaged as our holiday gift to you.
Welcome to Essentials in Pediatric Neuroimaging. I'm Elaine. I'm Chief of Service from the Department of Radiology, Hong Kong Children's Hospital. This presentation is on retinoblastoma, the essentials. I have no disclosures. So in the next 20 minutes or so, we will go through the epidemiology and clinical presentation of retinoblastoma, genetics of retinoblastoma, how we stage it and why a radiologist needs to know, and what a radiology needs to know about imaging techniques and lesion characterization. And finally, we will talk about treatment and surveillance. Retinoblastoma is the most common intraocular malignancy in children worldwide, with an estimated incidence of 1 per 16,000 live births. Worldwide, approximately 8,000 children develop retinoblastoma each year. It is diagnosed by the age of 3 years in 80% of the patients, and by the age of 5 years in 95% of the patients. Incidence is similar across all populations, and there seems to be no known geographic, racial, or gender predilections. Retinoblastoma presenting feature is a white pupillary reflex called leukocoria, and it's often recognized first by the parents. Strabismus and decreased vision are also common. Patient with advanced disease can present with iris color changes and enlarged cornea and globe, orbital inflammation, and exophthalmos. Retinoblastoma originates in the photoreceptor cell of the retina and is associated with a mutation in the RB1 gene, which is normally responsible for tumor suppression. Retinoblastoma results from a biallelic mutation of RB1 gene in developing retinal cells, following the two-hit model of tumor suppressor gene inactivation. In germline retinoblastoma, a mutated RB1 allele is inherited from a parent and is present in all the cells of a child's body. A second mutation in a retinal cell results in a tumor. Children with germline RB often present at a young age with a median of 15 months. Tumors can occur in multiple locations in one eye and in both eyes. A child that presents with bilateral disease is 100% likely to have a germline mutation. Non-germline RB affects just one eye and is the more common of the retinoblastoma. As the name implies, non-germline RB is not inherited from parents and cannot be passed on to future generations. It develops due to two random mutations in the RB1 gene in one cell of the retina. It is also known as sporadic or somatic retinoblastoma. Recently, it has been found that retinoblastoma may occur even in the presence of non-mutated RB1 gene due to activity associated with the MYCN oncogene. This is rare, occurring in fewer than 3% of children with unilateral retinoblastoma, and it tends to present at an earlier age, often before 6 months. Now, what do we need to know about retinoblastoma staging? Retinoblastoma is diagnosed by physical examination and classified as International Classification of Retinoblastoma, groups A through E, according to increasing severity, and it's listed in the table on your right-hand side. On color fundus photography, here is a group A tumor, which is a small post-equatorial tumor confined to the retina. This is a group B tumor, which is a foveal tumor confined to the retina. In this group C tumor, it's a retinal tumor surrounded by a cuff of retinal seeds, as indicated by the arrow. And here's a group D tumor, which shows diffuse vitreous seeding. And in this group E tumor is a large tumor touching the crystalline lens, resulting in elevated intraocular pressure and an expanded globe. In intraocular disease, the smallest intraocular retinoblastomas are well circumscribed and confined to the retina. Larger endophytic tumors are associated with vitreous seeding and exophytic tumors with subretinal seeding. There can be anterior chamber involvement, vitreous hemorrhage, choroid invasion, and lens dislocation. In extraocular disease, there is scleral and extrascleral involvement and optic nerve involvement. In retinoblastoma, there is focal therapy, which is proven to be effective only in relatively early disease, in particular ICRB groups A and B disease. Current treatment modalities include laser or cryotherapy. These are focal therapies. Also intravenous chemotherapy, intraarterial chemotherapy, and surgical enucleation. Surgical enucleation is recommended for advanced stage disease. Neoadjuvant and adjuvant systemic chemotherapy are recommended in advanced disease as well to reduce the recurrence rate and improve the overall survival. Therefore, precise identification of these features and accurate staging are important for oncologists and interventional radiologists to formulate treatment plan and estimate the prognosis for parental counseling. MRI is an important imaging modality in assessment of status of RB, and obtain high-quality imaging is essential in accurate disease staging. A summary of our institutional protocol is listed in front of you, and the most important radiological features will be illustrated in the following slides. Vitreous and subretinal seeding corresponds to group C and D tumor in the ICRB grouping. Vitreous involvement can range from small conglomerates of tumor cells to scattered, discrete tumor foci to diffuse involvement. RB that proliferates within the subretinal space between the retina and the choroid is termed subretinal tumor seeding. Subretinal tumor can be complicated by secondary serous retinal detachment and less frequently retinal hemorrhage, which will be discussed in the subsequent slides. Point to note is the gold standard of detecting seeding is by fundus photography, and the absence of seeding at MRI cannot exclude the presence of seeding due to its small size. So here is a 2-month-old girl with retinoblastoma involving both eyes. On the left, the axial T2 weighted image shows that there's a T2 hypo intense focus, and on the right, post-contrast scan shows contrast enhancement on the medial aspect of the right retina. These are suggestive of subretinal seeding. Retinal detachment corresponds to group D tumor in ICRB grouping. Retinal detachment in up to 80% of RB patients will resolve after chemotherapy, and 5-year survival can be up to 96 to 98%. This is a 23-month-old boy having retinoblastoma in both eyes. In the left eye, there is T1-weighted hypointense retinoblastoma with adjacent V-shaped T1 hyperintense subretinal tissue converging to the optic disc, as shown by the white arrow, which is a signature for retinal detachment. Vitreous hemorrhage is a high-risk feature of RB for distant metastasis, corresponding to group E in ICRB grouping. It is present in fewer than 3% of cases. Vitreous hemorrhage complicates tumor assessment in children with RB because it obscures tumor margins on clinical and MR imaging examination. So here's a 13-month-old boy with RB of the left eye. On T1, as shown by the arrow, in the dependent region of the vitreous humor of the left eye, there is diffuse increase in T1 hyperintense signal in the rest of the vitreous humor when comparing with the contralateral eye. This is suggestive of vitreous hemorrhage. Now, the choroid is a highly vascular layer underneath and supports the metabolism of the retina. Exophytic growth breaching the Bruch membrane can result in tumor invasion of the choroid between the retina and the sclera. Traditionally, enucleation of the globe is recommended for retinoblastoma with choroid invasion. Recently, more and more case reports have shown the success of systemic and intra-arterial chemotherapy in controlling such pattern of tumor growth. Massive choroidal invasion of more than 3 mm in post-enucleation histopathology indicates high-risk disease and warrants the use of adjuvant chemotherapy to reduce the risk of metastasis. This is a 40-day-old girl with left eye RB. The left image shows mural defect in the posterior aspect as indicated by the arrow. On the right, another mural defect at the lateral aspect of the choroid layer of the left lobe suggestive of invasion. Note that there is also aseptic orbital cellulitis in the left lobe, which is another imaging feature indication of high-grade retinoblastoma. The anterior segment refers to the anterior one-third of the eye. Anterior segment invasion corresponds to group E in ICRB grouping. Together with increased inflammation in the anterior chamber and direct reduction of its volume, it is common to have elevated intraocular pressure at the same time. Anterior chamber, ciliary body, or iris invasion may necessitate enucleation. On the left is oblique sagittal T2 weighted image, and on the right is axial T2 weighted image of a 19-month-old patient with right eye retinoblastoma. The large tumor in posterior aspect of the right globe is inseparable with the ciliary body and lens of the right eye, as indicated by the arrow, and it shows that there is anterior chamber invasion. The anterior chamber depth of right eye is reduced, which is suggestive of underlying raised intraocular pressure. Neovascularization corresponds to group E in ICRB grouping. It is hypothesized that the increase in vascularity can reduce drainage by the lymphatic system secondary to the mass effect of the retinoblastoma, promoting the vascular endothelial growth factor release. The leaky new vessels allow contrast leakage, shown by increased enhancement in the anterior chamber. Note the left eye of this 13-month-old boy with RALB. Axial image of T1 weighted post-contrast on the left and oblique sagittal T1 weighted post-contrast on the right show increase in contrast and enhancement of the anterior chamber in the left eye when comparing with the normal right eye. Retinoblastoma can promote inflammation of the globe, leading to aseptic orbital cellulitis. It corresponds to group E in ICRB grouping. Often, lens subluxation is seen at the same time secondary to ciliary body necrosis. Here is a 13-month-old boy with left eye RB. There's increased enhancement in the periorbital soft tissue in the left eye, involving posterior to the orbital septum, suggestive of orbital cellulitis. On T2 weighted image on the right, note there is T2 weighted hypointense tumor with posterior subluxation of the left lens. Assessment of the optic nerve is essential for accurate staging. Prelaminar and intralaminar invasion of the optic nerve are not considered high-risk features. Post-laminar optic nerve invasion, that is the involvement of the segment of optic nerve posterior to the laminar cribrosa, however, is a high-risk feature associated with high risk of orbital recurrence after enucleation, and mortality rate is up to 89%. Its presence is a contraindication to intraarterial chemotherapy, and the segment involved should be included for the enucleation to archive disease-free margin. Under MRI, the caliber of the involved optic nerve can be normal, while there can be abnormal enhancement or signal in the postlaminar segment to suggest involvement. Tumor spread into the intracranial space is uncommon and carries a poor prognosis. RB can spread through direct invasion via the optic nerve and its meningeal sheath into the intracranial compartment, and can metastasize systematically via hematogenous or lymphatic routes. Common sites for systemic metastasis include the lungs, liver, and bone. Whole body imaging, including CT, MR, or PET, are helpful in evaluation of metastasis in patients with such suspicion. MRI is particularly helpful in delineating the local regional extent of distant metastasis if local treatment such as resection or radiotherapy is necessary. This is a 10-year-old boy with surgical enucleation done for bilateral retinoblastoma when he was 2 years old. On the right knee radiograph, it shows that there's an ill-defined sclerotic lesion at the medial metaphyseal region of the proximal right tibia. Coronal T2 weighted image shows the aggressive bony lesion in the metaphyseal region of the proximal tibia with extension into the metaphysis and cortical destruction. Biopsy was subsequently performed and confirmed retinoblastoma metastasis. Finally, trilateral retinoblastoma refers to the presence of intracranial tumor histologically similar to retinoblastoma in the pineal region or suprasellar cistern, in addition to bilateral ocular involvement. This occurs in 10 to 15% of patients with heritable retinoblastoma. The incidence of trilateral RB is 3.2%, and these intracranial tumors can be synchronous with other intraocular RB at diagnosis, but are more commonly found on surveillance MR. The lead time from asymptomatic to symptomatic pineal trilateral tumor is approximately 1 year, and the prognosis of trilateral RB is poor. The presence of CNS tumor in both midline locations is sometimes referred as quadrilateral RB. Therefore, scrutiny of the pineal gland at presentation and on surveillance MR is important for detecting developing pineal region tumor. It is also important not to mistake pineal cysts for tumor, as pineal cysts are common incidental finding in the general pediatric population, particularly at 3T imaging. Now here's a 16-month-old boy presenting with extensive metastatic disseminated quadrilateral RB. Coronal T2 image from the initial MR showed hypointense retinal tumors in both globes. Now, sagittal post-contrast T1 image from the initial MR in image B shows a large enhancing mass occupying the sella, suprasellar cistern, and third ventricle with separate tumors involving the pineal gland and extending along the planum sphenoidal. Sagittal contrast image from MR 5 weeks later in image C shows that there is tumor growth, obstructive hydrocephalus, and leptomeningeal dissemination of the tumor within the fourth ventricle and along the brainstem and upper cervical cord. Now, lastly, treatment and surveillance. RB treatment is individualized depending on the IC-RB group staging, laterality of the involvement, germline testing results, institutional resources, and psychosocial factors. Current treatment modalities include intravenous chemotherapy, intraarterial chemotherapy, intravitreal chemotherapy, intracameral chemotherapy, consolidation chemotherapy with cryotherapy and transpupillary thermotherapy, radiation-based therapies, and enucleation. Post-treatment imaging includes tumor surveillance to identify local and intracranial recurrence, new intracranial or spinal CSF seeding, and development of trilateral or quadrilateral RB. The contralateral group must be monitored to identify metachronous tumor. Treatment-related complications include cataract, vitreous hemorrhage from radiation retinopathy, and endophthalmos, physis bulbi, myositis, nonspecific inflammatory changes, enhancement of orbital fat and optic nerve, and orbital and midface hyperplasia from external beam radiation therapy. Secondary tumors are seen in heritable forms of retinoblastoma, especially after radiation. Patients with germline disease are at increased risk for osteosarcoma and soft tissue sarcoma, melanoma, and malignancies of the brain and nasal cavities. So in summary, retinoblastoma is the most common intraocular malignancy in children, We must understand that there's a biallelic mutation of the RB1 gene in developing retinal cells, and it follows a two-hit model of tumor suppressor gene inactivation. We should be familiar with MR features indicating advanced disease because it is important for pediatric radiologists and interventional radiologists for accurately staging the disease and guide the clinical team for subsequent management. RB treatment is individualized depending on the IC-RB group staging, laterality of involvement, germline testing results, institutional resources, and psychosocial factors. And post-treatment imaging includes tumor surveillance to identify local and intracranial currents, new intracranial or spinal CSF seeding, and development of trilateral and quadrilateral retinoblastoma. With this, I'd like to thank you for your attention